I'm Dr. Michael Latola.
And I'm Megan Strong.
In today's case of the week, we'll take a look at some daytime splints.
And I'll show you a nonagenarian who puts his Buick where his mouth is.
And two feisty Florida field reporters force Florida to fluoridate. No comment from Florida. That and more on today's Chairside Live. Welcome to episode 51 of Chairside Live. Megan, how you doing?
I'm doing well. Today is my mother-in-law's birthday.
Oh, really?
And she is a big fan of Chairside Live.
She is.
She watches every week, so I'd like to wish a very happy birthday to Shelly.
Now, Shelly's not in the dental profession whatsoever?
Not whatsoever. She's a preschool teacher.
Preschool teacher. But she watches it, of course, because she likes to see me talk. And,
exactly.
And you do some of the stuff,
She's really
too.
interested in...
And what I have to say when we answer the viewer mail.
And Carrie's.
I don't think we probably have that many dental non-viewers, so that's good. We'll try to get those numbers up in season number 2. Well, Shelley, you'll be happy to know we have a case of the week that I think is going to fascinate you today as a preschool teacher. We're going to take a look at some daytime splints. And again, these are some thermally active splints, kind of like the ones we looked at a couple of weeks ago. But these are ones that patients can certainly wear at work because they're not very obtrusive. In fact, let's go ahead and take a look at that now. I was walking through the removable department the other day and saw this Galletti Articulator. I don't think most dentists have seen a Galletti Articulator before. It looks like something out of Transformers. I mean, it's kind of amazing when you look at this contraption and everything going on here. It's certainly a gorgeous articulator. I mean, I know it's not really practical for crown and bridge cases. Then again, on the other hand, it looks like something from 1908. But it's also shiny and new and gold and silver and pretty awesome looking, but it also looks, I don't know, just kind of odd the way everything works. But I always like these. I think they're really cool looking, and it's a great way to like show something to a patient. That's not what I want to show you. I was just admiring it as we were looking here. I wanted to show you a daytime splint, and this is an Astron splint. We've seen appliances like this before. I could probably bend this just a little bit right now, and if I had my hot water here, this is another one of those ones where I could just like a pretzel and basically just twist it. And it's got this wire reinforcement here. This is for people who want to be able to wear something during the day and don't want to have coverage on those anterior teeth and want to have a little room for their tongue. Only goes about a third of the way up the lingual of the anterior teeth, and they want to still be able to speak and have something in place. In fact, this Astron material can be made into something like a Gelb appliance, which is a pretty traditional TMJ appliance. Well, I mean, it's as controversial as all TMJ appliances are in one way or another. It's got the ball clasps, and then it's got the cast metal arm that goes around the lingual and doesn't contact the teeth at all. And most of the guys that I know that use this Gelb appliance use it for patients having a lot of TMJ problems, actually, pretty significant pain. And by keeping the posterior teeth in contact all the time, it does help people out, and people will get more comfortable with it. But of course, the danger is always that they'll be so comfortable they'll want to wear it all the time, and they can either get extrusion or eruption of the anterior teeth and maybe intrusion of the posterior teeth. Kind of the opposite of an anterior bite plane. All the things you hear bad about an anterior bite plane. Just the opposite can happen here with the Gelb appliance. So again, this one could be heated up. Won't bend the same way, obviously, because of the cast bar here, but if the patient has had a little bit of tooth shifting back here in the posterior segments, can be heated up, pop back into place, and have them bite together on it, kind of like this appliance too. So a couple daytime options if you're looking for a convenient material, easy to adjust, easy for the patient to put in some hot water and pop back in their mouth if they don't wear it for 3 or 4 weeks and it feels super tight when they go to put it back in. So a couple nice options using that Astron clear material as a daytime appliance. And then I saw one other thing as well in the removable department that I wanted to share with you, and that is something from the denture department. If we look at a couple of wax rims here for a denture case, we've always put the couple of teeth on the maxillary rim. We do this because we find it's just a little bit easier to get an idea, and it's just a random mold in a random shade. You don't have to read, you or the patient shouldn't read too much into these teeth. But it gives you a better idea when putting it in there of assessing the patient's lip line, and it helps us in terms of shaping the denture if we can get these first two teeth in the right position early on in the treatment sequence right now. And so when it comes to shaping it, they can be moved out facially for a little more lip support or back, or lengthened a little bit. And it's a nice time to kind of combine another part of an appointment into this one with those two teeth that are there, and really kind of use it as a determination. Obviously, we're going to be probably melting a lot of the occlusal surface of these rims to get the patient's vertical as we go through and determine their vertical and melt that. But the one thing we notice is when it finally comes time to hooking the two occlusion rims together is where we kind of get some issues. And there's a lot of mush bites being taken and other things being taken. Most typically the mush bite. I wanted to show another way to be able to do this in a way that really ends up with some accurate results. So once we feel like we've got the patient's vertical, where we want it, typically what we'll do is go in and just cut some notches. So I'll cut some offset notches here with a barred Parker. And you can see it's just a triangle cut into the wax rim here and the wax rim here. And the same on the upper as well. And I've seen, I've seen things like AluWax be put in there and other things. But I just like these simple kind of notches being cut in there. And then we'll take a knife and score that together. And so we'll just take a knife and we'll put a little mark down there so we can see that the patient, when they close back together, this is our way of verifying that it's going to be in the correct position. So it's kind of like when a patient closes into a double arch tray for a crown and bridge impression, and then we look at the teeth over on the other side to make sure the unprepped teeth are together so that the patient's biting down correctly. This is our way to make sure that they're biting down correctly. So we put the notches in here and offset them, and then we simply squirt some bite registration material. Obviously this is set already, but we would squirt some unset bite registration material in between the rims and have the patient bite together into that bite registration material. And then we just want to verify by clearing it. Take an Explorer, just take a perio probe, and verify that in fact the two cut marks that we have there together do in fact match up. And as long as those are together, we know that the patient has in fact replicated the bite for us that they were doing before. Because with no teeth on these occlusion rims, it'd be very easy for them to slide to the left, to the right, protrusively, especially protrusively, and us not really notice it because it's difficult there's no way to really gauge that unless we put some kind of mark there so we can tell that they are in fact in the correct position once we have them there. When that bite registration sets and the patient tries to open, usually something will happen. It'll either pop off the lower like that, sometimes it will stick together and maybe the whole lower comes off and you can take it out as a unit. Regardless, it's very easy after 60 seconds with the bite registration material to reassemble this and send it back to the laboratory and really give us some good information. Because we've got a ton of information on here now. We've got the patient's vertical, we've got a very accurate representation of where we want centric relation, and then we've got lip support, we've got tooth length, we've got all kinds of good stuff on this case when it goes back to the lab now. But we see a lot of doctors just kind of heat up these rims and push them together or put some other kind of wax in between the two. And the way of doing the notches, and then the big thing is putting the line on there as well. We really need to make sure that once we're happy with where the patient is, once we stick something between those rims, that they bite down the same way.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Doug, who also goes by Mullerman according to his email address, and he writes, "Dear Dr. Datola, I have really appreciated your expertise in various aspects of indirect restorative dentistry. My practice and skills have truly benefited from reverse crown prep technique, impressioning ideas, various products, videos, etc. I did have a question regarding your treatment planning decision regarding inlays and onlays. In your experience, how well have they performed? What thoughts go into your decision-making tree? Where would you avoid these? I have attempted to be conservative and do more inlays and onlays. However, they are time-consuming, very technique-sensitive, hard to provisionalize, final bondings are tough too. So my practice is fairly busy and it is hard for me to find times to do these properly. In short, I am wondering, are they worth it? Any input, thoughts, and advice that you could give would be very much appreciated. Thank you, Doug."
Well, thank you, Doug, or Molar Man, looking for Molar Woman, I suppose. I don't know, maybe you're married. That's a great question, Doug, but it's a difficult one to answer. I would have preferred something easier, like asking me to prove or deny the existence of God, but since you've decided to go down this road, we'll do that. It's tough because, like a lot of things in life, there is no right or wrong answer. And so you're right, you have to kind of make decisions based on what's in the best interest of the patient. And I never liked when I would explain to a patient how great this restoration was, an onlay, for example, that I was going to do for them. And this onlay was going to save a lot of their tooth. We weren't going to have to grind it all down like a crown. In fact, this restoration was so good, their insurance was not going to pay for it. But they would pay for it if it was a crown. And, you know, I used to like to point out the irony to the patient that the insurance company paid more for me to go in and remove all the enamel, but if I wanted to be conservative and not do it, it would get reimbursed at a much lower level. The irony was lost on the patient. The patient ended up being kind of confused. They didn't get that I was trying to say that their insurance company didn't have their best interests at heart. And a lot of times confused patients just kind of go, you know what, yeah, let's make it for next Wednesday, and then they don't show up for that appointment. So I kind of stop that approach, and I found a lot of the same frustrating things that you do, you know, with regard certainly to the temporary and keeping it on there and all those things. So when I started here and had access to a CEREC machine, that's when it started to change a little bit for me, because all of a sudden I didn't have to worry about that anymore, because we were able to place these in one appointment after milling them, and this coincided with the launch of IPS Emax, so now I had a stronger material to be able to use. Since then, I've gone to Bruxer, our solid zirconia product, for inlays and onlays. But it's still a difficult thing to try to figure out when to use it. When to use it clinically and not to use it, I think, is pretty straightforward. You know, as you look at some of these teeth and you notice that the two lingual cusps are in pretty good shape, and you just need to shoe one of the buccal cusps and take out the old amalgam and blend it all together. Definitely a more difficult preparation, as you alluded to. There's no doubt about that. And definitely more difficult to temporize and place, for that matter. It's just so much easier with a crown, and most dentists I know have a higher crown fee than they do for an onlay fee, so why would you ever want to do the onlay? It's kind of like veneers. You know, a lot of the dentists that when I was going through LVI and teaching at PAC Live, a lot of dentists I would talk to had a higher crown fee than they did veneer fee. And so, and veneers are certainly, I would say, like an onlay, more difficult to prep, temporize, and then cement when compared to a crown. So I would say that the onlay fee almost needs to be higher than the crown fee for it to feel like a rewarding procedure and to be compensated for the extra detail and time and skill that goes into it. And of course, you can't really do that probably on your insurance patients, and that would leave you doing it on the patients without insurance, where they were going to pay out of pocket. And so it was just a simple decision between you and them what was going to be done. And that's kind of where I ended up. I mean, it's a compromise, absolutely, and it's not the ideal way to do it. I look at my dad, who was a dentist for 28 years, and he did lots and lots of gold inlays and onlays without giving the patient much choice in the matter, frankly. And I saw some of those patients after he retired, and they begged me to take the gold out and put some tooth-colored materials in. And I would sometimes, if they begged enough, I would do that, even though I knew in my heart that gold was the better restoration. So it's the same type of ethical dilemma like that when you look at something like gold versus tooth-colored, because we know how good gold is versus the tooth-colored. And so it is that same kind of thing, and it's up to each one of us to find kind of a comfort level where we're okay with it. You know, here in the laboratory, a lot of the times I'm working on employees, and they're not being charged at all. And on them, it's a really simple decision to what we're going to do. We do whatever the most conservative solution that I feel is going to work. And it's amazing how when you take the money out of it like that, all of a sudden you begin to see what real, you know, diagnosis looks like. And you see people saying yes to things like no prep veneers, and there's really, to them, a lot of times no difference between 4 crowns and 8 crowns. In fact, when there's no money changing hands, the patient who gets diagnosed needing 8 crowns is usually more excited than the patient who needs 2 crowns, the exact opposite of fee-for-service dentistry. So I've been biased now, working without kind of any money exchange, and I find myself doing more partial coverage restorations that I did in private practice, where I tended just to keep it to the patients who didn't have insurance so it didn't get too confusing. If I had really good rapport with the patient, it was a different story, and I could explain the difference to them and why I wanted to do the more conservative restoration. So I think it's difficult to have a broad policy for everybody, and I think you really almost need to take it on a case-by-case basis with each patient. The idea of just measuring between the cuss tips and bam, this makes it an inlay or an onlay or a crown, I think that's difficult to do when you take into account the realities of the fact that most of us accept insurance. So it's one of those ones that we could probably argue for days and hours, and I promise you this, Doug, the next time we have Gordon Christensen sitting behind this desk, I will ask him about that as well and what he does in his practice. But I know it's that same type of thing where you're sometimes going, prepping a crown, going, this probably could have been an onlay. My other thing is I like to prep what I call small crowns or large onlays, things that approach the height of contour on the tooth. And so it might appear to be an onlay, but it's a crown. It covers the entire occlusal surface and onto the proximal surface. You know, where does a large onlay stop and a small crown start? I'm not sure, but when I'm in that gray area, it's certainly comfortable enough to call that a crown. So thank you very much for your letter, Doug. And by the way, for all of you who write in because of the opportunity and the chance that you might be the letter of the week, we would love to have your last name and your address of your office in case you are the winning letter selected, because all I know about you, Doug, right now is that your first name is Doug, and a couple people call you Muller Man. I don't know who, but I know that it's in your email address, as Megan pointed out. So shoot me an email so we can get you that information. Thanks for being the letter of the week. And Megan,
yes.
What does Doug receive for being the letter of the week?
Well, before we get to the prize, we've got a bonus letter of the week, and you're never going to guess where this doctor's writing from. I think he wins the award for the viewer, the most remote viewer, the farthest away from here.
Alaska.
Nope. Nice try. It's that he's actually from Iran.
Really?
Yes. And he writes, it's Dr. Farzan, and he writes, Dear Dr. Datola, greetings from Iran. Do you have any experience with ceramic burrs called tissue trimmers? Thanks, yours truly, Dr. Farzan. And he writes, P.S. Your crown prep technique has changed my way of dentistry. It's amazing watching your videos and these episodes of Chairside Live.
Wow, in Iran?
Yes.
That's pretty cool. That's neat in Iran, and I don't know what CE looks like over there, but with everything available on the internet now, that's pretty cool to know that, and he must speak English, obviously.
Yes.
He writes in English, and so thank you for writing in. Yeah, those ceramic tissue trimmers, though I do have some experience with those. I used to use those pre-diode laser for the most part, before the diodes came out and really got affordable. Just very slow, extremely slow. And you know, I just remembered the other day how slow a diode laser is. Because of the fact that I took out my electrosurgery because I had to do a bunch of recontouring, and I had forgotten how fast it was. I had just gotten used to the diode laser because of working around amalgams and implants and things like that, and I'd forgotten that the electrosurge just flies through tissue, and it's really a great feeling once you're adept at recontouring tissue. But a diode laser, they're down like the AMD lasers, the Picasso Light, the one that I use, is close to $2,000 now. I mean, so it's not a huge investment. And it's certainly faster than the ceramic tissue trimmer. But I did used to play with those. I'm just not a huge fan of them. They're just too slow. But even sometimes the diode feels slow compared to the electrosurge. But of course, the electrosurge, you can make more mistakes than you can with the diode. I don't even know if we can ship a coffee mug to Iran. So instead of this, I will give you my best wishes, a virtual handshake from RoboMike. Uh-huh. And because I don't think we can ship to Iran.
I don't know.
I'm not sure if we can or not, and I don't want to start any kind of, I don't know, any kind of international incident if we ship a burr kit over there. But thank you for writing in, and thank you, Megan, for that. And so what does Doug win since he is in the continental United States?
We've got something for you, buddy, right here. Chairside Live mug.
Wow, and I've got something else for him. We've got the aforementioned reverse preparation kit. Enjoy that,
Nice.
Doug. And we have, what is this?
That is my lip gloss.
And we have Megan's lip gloss. Wow, what a find that is. Wow, that's we're going to have doctors arguing over that.
But hey, don't you dare forget, what would a viewer mail prize be without the Chairside Live autograph photo?
That's right. That's right. Yeah, and by the way, this just in, when these mugs are out, I think there's another item coming, a different item besides
stay tuned.
The mug itself. So who knows? We might have a whole variety of items that people can fight over and put on eBay and become $1.50 richer if it sells on eBay.
That'd be
Megan,
great.
we have any news today?
We do. You may remember on episode 29 of Chairside Live when we discussed a county in Florida's wishy-washy stance on fluoridation. Well, two staffers at the Tampa Bay Times have won a Pulitzer Prize for their coverage of that fight to fluoridate. Editorial editor Tim Nickens and columnist Daniel Ruth were honored for a series of 10 editorials condemning the Pinellas County Commission's decision to stop fluoridating the water. The pair's editorial efforts are credited for bringing back water fluoridation for the 700,000 residents in the county. The Pulitzer website states that Mr. Nickens and Mr. Ruth were honored for their distinguished editorial writing and the power to influence public opinion in what the writers conceived to be the right direction. The duo will receive a certificate and a $10,000 cash reward.
Wow. Is that a Pulitzer comes with a $10,000 cash reward?
I guess so.
That's amazing. And we did report on that, and it was
did.
kind of funny to see them going back and forth like that.
Right.
And we poked a little bit of fun at it. But that's one of those stories that, that's what I like to hear. Some good old-fashioned reporting. People go out and get educated. It was an editorial, of course. They were trying to influence the public as to what they thought was the proper, which happens to be what dentistry thinks. And again, it just cracks me up that why would dentists be pro-fluoride when it's going to create less work for us to do?
Right. That would make no sense.
Yeah. Why? What crazy ulterior motive do we have where we going to promote this and we want it in the water supply, even though it's going to reduce the amount of cavities that we're going to see if it wasn't in the public interest, and it certainly is. So that's really neat to see that two reporters were able to have that kind of power, get that decision reversed, and now that 700,000 person community, and especially the children growing up there, if they don't have the benefit of multivitamins with fluoride and things like that, they're going to be able to get some fluoride in their teeth and maybe, like me, be cavity free, because that's my dad had me on a chewable fluoride multivitamin, and I'm pretty sure that's why I've never had a cavity. So good for them.
Yeah, and as a writer, I of course co-host this show, but my day job, if you will, the time that I spend working when I'm not filming the show, I'm a writer here at Glidewell, and it makes me proud to see two writers be able to influence public opinion and be able to win such a highly esteemed award. I think it's great.
Yeah, if you can write something to keep them from overcooking the vegetables up in the cafeteria, I may not give you a $10,000 prize, but it will be, let's say, $10.
Perfect.
Yeah, and maybe a mug and a signed picture of just me without you in it.
Then you've got it. You've got a deal. Let's shake on it.
Very limited edition.
Right.
Anything else?
Yes. There's Superman, Batman, Spider-Man, and Mike Greenstein from Queens, New York. The 92-year-old is known as Mighty Atom Jr. and is known for his superhuman strength. The senior daredevil will showcase his extraordinary talent pulling cars with his teeth at an upcoming show in Coney Island. The 5'4", 145-pound great-grandfather will strap 2 ropes to the hood of his 2006 Buick LaCrosse and attach the cords to a leather strap which will go in his mouth. Mike says he's preparing for the event by eating a lot of strawberries, apples, oranges, and salad. All you dentists out there might be having a heart attack right about now, but he says it's not the teeth doing the work. He claims if you clamp down hard enough, it's the jaws, neck, and leg muscles doing all of the work.
Wow.
Unbelievable.
Those are two words you don't usually hear next to each other. Senior daredevil.
Right, ever.
I mean, usually daredevils don't live to be that old. So this must be something he took up later in life.
He did actually, and he learned it from his father, who was a famous sideshow, performer in the 30s in Coney Island. And so he picked up the trade from him, but he had a day job throughout his life, but then just did this on the side, and this is his first show.
And he's preparing for it by eating apples and
oranges and strawberries and salad.
How does that prepare you to pull a car
I don't know.
With a rope in your mouth?
I'm not sure. I would imagine maybe lean chicken breasts or something, but no, strawberries and oranges.
But I think he's right. I can't see it pulling any teeth out. I can't see it really doing any damage to the teeth. I can see it jacking up his neck.
Sure.
Maybe, or...
I just feel like that would hurt your jaw so much to have to pull that in a 2006 Buick LaCrosse. That's not a little beetle or bug, you know what I mean? That is a large car.
Right. When's this happening?
I think it's coming up next week, actually.
Really?
Yeah.
I wonder if there'll be, is it going to be on one of the major networks? Have you heard? NBC?
I don't think
ABC,
so. I
CBS,
doubt it.
Internet?
No.
Maybe?
Maybe the internet.
Maybe the internet. I'd like to check that out.
That would be incredible. Hopefully they air it online or something so that we could see this
Hopefully he needs a new
92-year-old.
bridge, and we can have Dennis put a Bruxer bridge in there, and
Yeah.
maybe that would make it even easier. Or Senior Daredevil, we put a Bruxer bridge in his mouth and do that intraoral hammer test that I've been wanting to do on somebody, and I can't find somebody to do
Yeah.
it. That's what I need, is a Senior Daredevil.
As a daredevil, I think he might be up for it.
Right, exactly.
We'll
He could
see.
be our own little Glidewell Evil Knievel. Bring him in here and do crazy things to him with Bruxer.
I like it.
All right, thank you, Megan. Appreciate that. That about wraps it up for this week's edition of Chairside Live. On behalf of myself, Megan, the whole crew, and everybody here at Glidewell Laboratories, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
And two feisty field reporters in Florida. In today's case of the week, we'll take a closer look at some daytime splints.
And I'll show you. I'm sorry, it sounded like you were chewing on cheese for a second.
And two feisty Florida reporters.
A genarian who puts his Buick where his mouth is.
And two reporters force a Florida county to fluoridate.
Come on, dude.